So integrated primary care is really a new kind of primary care. Historically, primary care has really come from a medical model. The clinicians in primary care were medical providers, MDs, nurse practitioners, physician's assistants. And that model is really excellent care for the physical health needs of patients. But what we know is that 70% of primary care office visits are actually driven by psychosocial, psychological, and social variables rather than physical health concerns. Given that, it really pushes, from a logical standpoint, if we wanted to improve primary care, really a different kind of primary care that we would deliver rather than just a biomedical kind of care, but instead of biopsychosocial care. And for us at the county, how we've moved our practices from a biomedical model to a biopsychosocial model, we've really focused on staffing. We really have made a commitment to hiring specialists or behavioral health providers, LCSWs and psychologists who are trained for years to manage psychological and social issues, really staffing them to the level that they need to be to actually provide biopsychosocial care to a population. So about 5 years ago, we started on our journey of creating integrated primary care. We had the medical home, we just didn't have a biopsychosocial approach. So 5 years ago, we designed a model that had this team with all of the components we already had, that also included a behavioral health clinician at such a level that the behavioral health clinician could actually provide support to the population. And also that the behavioral health clinician would work providing brief assessment, brief intervention, cognitive behavioral, and identification of more significant issues and coordinating that care to the specialty programs. So the strategic plan was to staff up behavioral health providers to such a level that one could put them on teams and assign them populations to take care of, and then also to train the behavioral health providers to work in this different kind of brief assessment, brief intervention referral way. Because behavioral health providers aren't trained to do that. They're trained to work with about 60 cases and work with them for months to years. But in primary care, we want a behavioral health provider to work with our teams and take care of 2,500 to 3,000 patients and be immediately available at the patients when the patient needs it. So the patient comes into primary care today and they need to talk to a behavioral health provider today, and we wanted to be able to provide that. So I mentioned behavioral health providers aren't necessarily trained to do that. We actually consulted with Mountain View Consulting to train all of our behavioral health providers, the existing ones, and then all the additional ones that we hired over the course of the last 2 years. We went from 8 behavioral health providers to now 18 behavioral health providers over the last 2.5 years, which has allowed us to have 1 per 3.4 PCPs. My focus has been on setting the foundations of a care team that logically makes sense. For taking care of people who are biopsychosocial beings, we need a care team that can do that at the highest level in primary care. That's been the focus. From here, now that we have that, and I would say we had that May 2016, so a couple months, now it's all innovation from there. Now I can give the reins to the PCPs and the behavioral health providers working together and say, okay, now things are coming in. So now you've got depression and anxiety coming in. You used to do it this way. They used to come in and see their primary care provider and they get an antidepressant. Well, now you have a psychologist on your team. What could you do different? Diabetes, any kind of chronic disease that requires changes in thinking and behavior, your behavioral health providers are well trained to be able to help with that. When patients have to change the way they're thinking about something, the way that their lifestyle is, their behavior, what a resource to have people who have been trained for years to help people make the changes that they want to make. So we are resourced with our team to take care of, really, in my mind, any kind of issue that would come in, from the mental health to the physical to the substance abuse. We are resourced well in our care teams. We'll be able to support them. We'll either identify what's going on, briefly treat them, or we'll identify that specialty treatment is necessary, and we'll have a really nice way of coordinating that care between our program and other programs. So we have what we need.
Safety net clinics, historically community health centers and federally qualified health centers, in general have had a higher concentration of patients with multiple complexities, social determinants of health that we haven't that we aren't very good at addressing in healthcare, mental health, behavioral health, all of those elements in addition to physical health. And so when you're a primary care provider coming in to provide services to patients who come with all of that, and it's all on you, it's quite a load. And I think the burnout for primary care providers can be quite high in that realm. So with this team expansion to help support a lot of the help in the care of those elements of our patients, I think it really does have a benefit to recruiting primary care providers into caring for the underserved and patients. There's also more satisfaction in your job when you get to work in a team environment. I think a lot of us did that when we were in training. We practiced with teams, and then you go out into delivering primary care and you're by yourself in this little bubble, you know, and I think that it's a gift to be able to share that experience with other people, learn from each other, and apply that to the practice of medicine.
When I initially came to the clinic, they actually thought that I was a pharmaceutical rep for an entire first 2 weeks. And once they actually figured out what I did, they weren't exactly sure what to do with me at all. So I think for everyone there's a long learning curve for what the practice really is supposed to look like, because it's very different than a mental health practice in general. And so there was, and I think the process of being innovative in that way is you have to be patient for everybody's learning curve for how to work with you. And so there was probably 6 months to a year of just getting the flow of a fully embedded integrated provider in the clinic. And then kind of adding on to that what the scope of things that embedded providers work on. We don't just see people with mental health issues. We see people with a variety of issues, whether it be people just having a hard time adhering to behaviors with chronic disease management or tobacco cessation, or adjusting to chronic disease states such as hypertension or diabetes. Those initial processes of embedding a provider in a clinic can feel a little bit shocking. You'll discover that your population is affected by more social and psychological issues and potentially substance use issues than you anticipated. And that can feel a bit daunting and overwhelming as you get started in that process. But that, I assure you, after this many years of service in integrated settings, that is a normal part of the curve, is that you will discover more than you think you had. The cool part about it, though, is now you have the resources to do something about it. And so that's the upside of that process, is that you have somebody that's willing to run into the fire and deal with all of those issues that you find.